Greetings of the day. We are going to discuss about crush injury and the crush syndrome. A crush injury occurs when a body part is subjected to high degree of force or pressure, usually after being squeezed between two heavy or immobile objects. Crush injury that produces ongoing ischemia of a facial muscle compartment is termed as a compartment syndrome, defined as an increased pressure within a confined space that leads to microvascular compromise and ultimately leads to cell death as a result of oxygen starvation. Crush syndrome is a systemic manifestation of the muscle cell damage resulting from pressure or crushing with or without subsequent compartment syndrome. So, crush injuries may be seen in two different categories: in a single patient situations and in the disasters of varying magnitudes, such as earthquakes or tsunamis. Catastrophes have occurred throughout the history, but the recognition of the crush syndrome in the 20th century and the advent of the effective treatment for some of the components of the systemic and local injury have made it one of the important aspects of medical care of the natural disaster victims. The increasing number of vehicular and workplace accidents has also led to the rise in the incidence of the crush syndrome and the importance of its timely recognition and treatment. In various reports, the incidence of the crush syndrome and subsequent renal failure varies from 1% to 25%, probably resulting from reporting differences, the nature of the disaster, and timeliness and effectiveness of the rescue efforts and medical care. Crush injuries are most commonly seen in extremities because crush of the trunk or head and neck is quite quickly lethal. There is high incidence of associated injuries such as fractures and lacerations and degloving injury. Care of crush injury patients in the setting of the mass casualty incidence is radically different from that of an individual patient. Extrication may be delayed, medical treatment during excavation may be unavailable, initial management may require and makeshift or suboptimal conditions. The medical personnel may have little experience working under such conditions. Transportation to a definitive treatment may be prolonged. Critical equipment such as dialysis machines may be in short supply, and the laboratory monitoring and intensive care facilities may be insufficient for the volume depends. Healthcare workers should anticipate these obstacles and develop flexible treatment protocols. So, coming to the pathophysiology of the crush syndrome, so there is injury to the muscle involving crush and ischemia. So, this causes a rupture of the sarcolemma and release of intracellular contents of the myocytes into the surrounding tissue. Calcium ion is one of the most destructive components released from the myocytes, and because calcium stimulates the proteolytic enzymes and oxygen-free radicals are released, this causes myocyte destruction for potassium phosphate and myoglobin, creatine kinase, and uric acid leak into the bloodstream. Serum haptoglobin binds some of the myoglobin, but its binding capacity is quickly overwhelmed, and myoglobin causes a direct kidney injury. Membrane damage to myocytes and to the systemic capillary endothelium causes vascular volume loss and hypovolemia. Hyperkalemia and hypocalcemia may cause arrhythmias and cardiac arrest. Metabolic acidosis caused by hypovolemia and shock aggravates arrhythmogenicity. Renal failure is most serious complication of crush syndrome. The pathogenesis of renal failure is multifactorial, including systemic hypoperfusion, renal vasoconstriction, nephrotoxicity from myoglobin, and uric acid and phosphate precipitation in the distal tubules. Low urine pH and renal vasoconstriction promote precipitation of the nephrotoxins. Myoglobin is indirectly nephrotoxic through the formation of ferrihemate, which produces free hydroxyl radicals, and combined with lipid peroxidation damages the kidney. Reperfusion syndrome is a paradoxical phenomenon of exacerbation of cellular dysfunction after restoration of the blood flow to the previously ischemic tissues. It involves biochemical and cellular changes causing oxidant production and complement activation, which culminates in an inflammatory response mediated by neutrophils and platelet interacting with the endothelium. The inflammatory response has both local and systemic manifestations. The systemic manifestations include hypertension, vasodilatation, hypovolemia, myocardial dysfunction, hyperkalemia, and acidosis. Normal muscle compartment pressure is less than 10 millimeters of mercury. After crush injury, trauma to the microcirculation leads to edema formation, interstitial bleeding, stasis, and obstruction, and myocytes are no longer able to retain intracellular edema. Edema in closed spaces leads to increased pressure, which further collapses the microcirculation and potentiates the problem. Pressures more than 30 millimeters of mercury produce muscle ischemia, irreversible nerve and muscle damage occurs after 4 to 6 hours. Now coming to the clinical features, obviously external signs of the crush injury are usually evident as a suggestive history. Laceration, degloving, deformity, pain and ischemia may occur. Compartment syndrome often presents with 5 P's, that is pain, paresthesias, passive stretch, pressure and pulselessness. Pain is the most common and consistent symptom and described as a diffuse and intense and exacerbated with movement, touch or pressure and out of proportion to physical examination findings. Paresthesias are numbness, tingling or the burning sensation in the affected area. Severe pain results when the muscles in the affected compartments are stretched. Affected compartment is very tight to examiner's touch and sometimes warm, and there are measurable increases in the tissue pressure. Pulselessness occurs only in the late stages. Examination for pulse or its lack is the least reliable because compartment syndrome is a disorder of the microvasculature, not major vessels. So we can't rule out the compartment syndrome with the presence of pulse. So you can see the pulselessness is the last component of the 5 P's. So initially you have pain, paresthesia, passive stretch, then pressure, sensations. So crush syndrome is due to manifestation of muscle toxin release and hypovolemia. Hypovolemic shock may occur aggravated by hypokalemia, hypocalcemia or acidemic cardiotoxicity. Thromboplastin release may cause disseminated intravascular coagulation, which is especially critical in the face of tissue damage, open wounds or the need for surgery. Renal failure may ensue quickly and is the primary cause of death. Okay, so coming to the treatment diagnosis, how do you diagnose a compartment syndrome? So testing is related to like the testing of the compartment syndrome pressure will confirm the diagnosis. A compartment pressure of more than 30 millimeters of mercury is considered to be positive test. Measurement is best accomplished by a dedicated device, that is Stryker. That is Stryker. It is done with STIC. It is produced by Stryker company, and or by inserting a saline-filled needle connected to an intravascular pressure measurement system, that is arterial or central pressure venous pressure gauges into each compartment and recording the pressures. This is very tedious when compared to the normal device. So crush syndrome is characterized by protein and rapid metabolic changes. Laboratory tests are crucial to help direct the management. Serum creatinine levels may not necessarily predict the disease severity and risk of renal failure, but they are useful initial triage and subsequent follow-up too. We need to pay close attention to the serum potassium, calcium, phosphorus, pH, creatinine, hemoglobin, coagulation indices, and the urine pH and electrolytes. A pre-planned sequence of laboratory tests every 2 to 4 hours is useful. Okay, so we need to do all the tests and rather than sporadic checks. So the urine collection for total electrolyte excretion and creatinine clearance calculation may be considered in these patients. So establish 2 large bore IV lines and administer normal saline with 1 to 2 liters bolus.